Before the questions, you're chief resident, correct?
Yeah.
Okay, Dr. Plonsker, I'm going to put you on the spot.
Okay.
There were two polls recently which were published,
Sure.
respectively of 15,000 cases each,
Okay.
of out of polls of neurosurgeons worldwide, where the top hitters, some of the two studies were somehow partially overlapping for the number of the heavy hitters, but they were the heavy hitters worldwide about Chiari malformation surgery. So 15,000 surgeries done on one side, 15,000 surgery down the other side. And, we asked the same things about what are the ingredients to the Chiari malformation and what do you use, what you don't use, etc. And stratifying we stratified by experience, and obviously there were people with less than 300 cases done in their lifetime, with 600, 900, and then about 1,000.
Okay.
So once we stratified, the people who, the surgeons, and it didn't matter if you were pediatric neurosurgeons or adult neurosurgeons, all the people who had above 900 cases of personal experience, they all did posterior fossa decompression, opening the bone. They all did the duroplasty, and they all used the same material, which was autologous pericranium. They all did tonsillar shrinking. Obviously, the problem is, as you know from experience, once the first times you do a duroplasty, it leaks, especially beat up dura or children dura, and it's pain. You stay an extra hour trying to sit. Then you put the magic glue on top, keep the fingers crossed. You come out like this, not to talk to the parents. But the reality is that it's like tying your shoes. The more you tie your shoes, unless you're like me, that took me some 3 or 4 extra years. By age 10, you know how to tie your shoes, and you're not gonna have problems. So the incidence of cerebrospinal fluid leakage below 300 cases was obviously more in the pediatric population than in the adults, but was between 18 and 48%. Once you pass the 600 cases, and obviously you have to open the door to get the experience up, it goes to single digit, and it goes to between 0.5% and 1.5% for all the people who are above 600.
Yeah.
So if you do not open the dura, you will never get
better
that great at it,
Yeah.
which was Dr. Oaks was saying. Okay, so I'm not saying she's wrong. I was just saying it's a little bit more complicated once you put all the people in the pot.
Yeah.
But there is nothing wrong about being prudent on the way to the experience. And she's still a resident, so it's good. I was so bad that I had to do residency twice. Once in Europe, once here.
I just have one question. This idea of extending the alliance to international other countries is pretty great, but I can also say that your experience here in the U.S., I've had to train every neurosurgeon I've ever gone to see about Chiari. And so with this idea of expanding the alliance, whether it's internationally or locally, how can patients be part of that? How can we be proactive about being pushy? I guess is the best word. How can we help you? How can we be a team with the providers to provide the best outcome? And that's anybody.
The objective of this, or one of the objectives, is to gather the experience of other patients or other forms of other, maybe the complications, because we have to bear in mind what the Dr.
Plonsker.
Yeah. Dr. Plonsker said in her magnificent presentation, there is an 80% or 85% success rate which means there is a 15% failure rate. And if you are told that aeroplane you're about to board has 15% chance of crashing, you'll say, okay, I walk. Thank you. And that 15% that we collectively could not solve may demand the opinion of other people. What our group of ET patients can do when we bring our ET surgeon next year, the first one of the ET series, hopefully will be a long series, is engage in a conversation, showing also that you as the patients have an active mind, no? I mean, be the example of the patients. I have this problem, that problem, or the other problem. They're engaging in the conversation with the visitor is an important aspect for the visitors learning and the example that they can take back to their countries, no? That the patients are, as you are, active members of this society, no?
First of all, thank you so much for being here. I know you guys have to come on your own time, and we appreciate that, especially for us being first time to this conference. We want to just thank you because it's eye-opening to hear this information.
We came here because it's San Diego.
Appreciate
We
that.
won't go to Chattanooga, you know.
I had a two-part question. One, the Duraplex that you were talking about, the patch.
Yeah.
Especially if it does leak and they have to go in and have a second surgery to fix the leak.
Sure.
What is the lifetime of that patch? Is it a lifetime patch, or is it have to get checked on from time to time?
We hope it's a lifetime patch. So these patches, especially the synthetic patches, they're designed so that your own dura heals and grows into it. The leak rate happens immediately before that healing has happened. And if fluid is coming through a hole, then that hole can't heal around the fluid. So it requires the seal to be tight and watertight in order for it to heal and close. So if there is a leak, often we'll have to re-explore it. But there's a couple different options for management. We'll either open up the incision again, which is a big surgery. We'll open up the incision and put stitches or staples in to close that hole. The other thing we can do is reduce the overall pressure of the fluid in the head to divert that away to make the path of least resistance no longer that hole. So that can be things like a lumbar drain or other ways to reduce the CSF pressure. But once we get that to be dry, then it should heal.
Excellent. Thank you so much. And the second part to that, you spoke earlier on the tingling and numbness that is associated with that.
Sure.
Years after a surgery, is that common to still have that, or is that a cause of concern? And that was it. Thank you.
I would say anytime symptoms are stable and your imaging looks good, then I wouldn't be particularly concerned because there is a subset of patients who are not going to have resolution of those symptoms. Anytime there's a progression of symptoms, meaning it's getting worse or the numbness and tingling is getting more extensive or denser, that's something that you might need to go see your surgeon about or your doctor about and get re-imaged. But there is a subset of patients who that numbness and tingling might not get better or might not even be from the Chiari malformation in the first place. A lot of these symptoms are a little bit vague and a little bit general, and that's what makes this a little challenging to treat.
Yeah. The bovine mesh is the bovine mesh is the a dura patch.
Mm-hmm.
So just bringing up options, and
Sure.
I just also have heard that you can use your own tissue as a mesh.
Yeah, so there are several different options. A lot of that, it's not, at least the way we do it, it's not like we present a menu of options. A lot of it's what the hospital has available or what the surgeon feels most comfortable with. I personally worked with a few different types of tissue substitutes that are made by different companies, and I already have developed a personal preference of what I think creates the best seal and what's the most easy to handle and easy to sew to. Using your own tissue, you can harvest a pericranial graft, which is just a layer of tissue in the head. it's always better to use your own tissue. Some small percentage of patients will have some irritation from having an implant like that, which isn't very severe, but it can cause fevers or headaches or things like that in and of itself. Yeah, so using your own tissue pericranium is possible. It's challenging, and it just depends on the person, because sometimes that's actually something you can sew, and sometimes it's really thin and not even usable. So it just depends on the person. Yeah.
So just a quick point. I've had the bovine patch for 20 years. Been working well. I've only eaten grass 3 times, and I only moo in the middle of the night. What I'd like to do, we have a few speakers that are here in the audience. I want to ask them if they want to come up and join the panel so that we can just open up the panel for more conversation. So then we actually have one from the question over here.
Yeah, I think Jill answered that question really well. I just want to speak to your question about the patch type. So there was a big study that came from the Park-Reeves Syringomyelia Research Consortium and Chiari's and Syringomyelia kids. And they found that patients' own patch, so autologous patch, had a lower leak rate, but the success rate for synthetic patches and autologous patches were the same. And so there is some incisional and self-morbidity that comes with that. You have to make a larger incision. Sometimes you can get scalp numbness from harvesting that pericranial graft like she talked about. So it's really a risk benefit. I tell patients about it, but I'll tell you 90 out of 100 times I use a synthetic patch because it's, in my hands, I think it's easier on the patient and the success rate is pretty equal. Thanks.
Yep. I'm curious what the longest lifetime you've ever heard of a patient taken to improve after they've had surgery? In years? Like if somebody had surgery, let's say 10, 12 years ago, and they have not had improvement yet, and their doctors are basically saying that, I'm sorry, you're on your own now at this point. So I'm curious if you have an estimated, I'm sorry to word it this way, an estimated length of time to how long it should take a patient to prove that they're going to recover from surgery.
Yeah, the traditional number is the traditional evolution post-surgery after a non-complicated procedure, which means the surgery went well. The surgery has been the most aggressive or, the most proportional you can do. So good surgery for a given anatomy is that at the 6-month mark, you should see already an improvement of something like 80% of your symptoms. And then there is a sort of an extended play which can go up to 12, 18 months later, but the improvement flattens out. And the same applies to the deflation, like a Syringomyelia, which goes down in size. Obviously, all depends what you're going to have. If you have a bumpy postoperative period, it's going to take longer before you start seeing these improvements. It also depends what are your signs and symptoms going in. If your chief complaint number 1, 2, and 3 is pain, somebody slashes you open, the incisional pain and the preoperative pain, they're going to overlap for a while before you sort them out. Yeah. But if by the 6th month you don't see anything, he's got one or two things. Either those symptoms were not coming from the Chiari-1 malformation. She was saying before, the majority of the people with Chiari-1 malformation on the face of the earth, they will never go to a doctor because they're symptomatic, which also means that somebody is going to get operated on under the assumption that incidentally found Chiari-1 malformation was the source of certain symptoms. So either the Chiari is not the cause of the symptoms that you're going after, these are not the droids you're looking for. Or number 2, the surgery is not, the symptoms were legit for Chiari, but there's been one or three things. Either the surgery was incomplete, so like I want to punch down Mike Tyson, but I just caressed him, it's not enough. Or number two, you have complications. Or number three, the Chiari has a partner in crime somewhere else that you are not keeping in account, which can be increased intracranial pressure, craniocervical instability, or anything else that usually are the partners in crime of this. So, but if you don't see any by the 6 month period, it's a problem.
Well, thank you. Basically everything is improved except for the headaches have not changed at all. They are extreme, and it's been over 12 years.
Yeah, don't forget also there's comorbidities. So there's 100 different variants of headache. So a lot of times, even though it's not a classic migraine, the headache may be non-Chiari related, because the headaches are usually the first thing that you see that will get better almost immediately, because it's usually a pressure related phenomenon. So if other things got better, but the headaches are still there, you kind of question if the headaches were part of the Chiari.
Thank you. Thank you.
Thank you all very much for sharing your expertise. We really appreciate that. I had some question about one of the slides had indicated that the shunting resolves most of the symptoms, the majority of the symptoms. And I'm just wondering, when you said a majority, what percent of people will only get slight relief from shunting? And how, even if it is effective pretty much, how long is that good for? Do you have to, at what point do you have to redo the shunt?
So I think you're asking me. I'm going to have to defer a little bit to my lack of experience here, but I'll say in my experience, I've only done a Chiari decompression for someone with a Chiari 2 once. It's very rare, and that's only when we've completely proven to ourselves that the shunt is working really well. It's much more likely if somebody comes in with Chiari-related symptoms due to a Chiari 2 malformation, not a Chiari 1 malformation, Chiari 2 malformation, that there's something wrong with the shunt or they're having insufficient shunting. So that may look like doing a shunt adjustment, doing a shunt revision, doing another shunt revision, changing out the shunt, another shunt. I think we would do all of those things before we would address the Chiari malformation.
There's an age-old saying in pediatric neurosurgery, it's always the shunt. And especially for those, it's usually the truth, yeah.
One of the primary issues, you're dealing with two very distinct problems. So you have those problems anatomically that are associated with the Chiari malformation, and then you have an imbalance of the production of cerebrospinal fluid, which is about 20 cc's every hour, and reabsorption. And hydrocephalus means that those aren't equal. So if you reabsorb 99.9%, you may compensate for a while, but then you have hydrocephalus. So the shunt, in treating the hydrocephalus, when that shunt stops working, can present in just a myriad of ways. It can be very specific. We have the classic of headache, nausea, vomiting, lethargy, but some people present with an exacerbation of signs and symptoms that be more consistent with the Chiari malformation. And that's the manifestation of hydrocephalus in those patients. Some people have excessive tearing. It can be extraordinarily difficult to discern amongst different children and different individuals. So I think that's the problem. It's the hydrocephalus for us is the primary problem because there's a morbidity and mortality associated with missing that diagnosis of a shunt malfunction. So that's why we pay very close attention to shunt function, and then as opposed to thinking of addressing Chiari type presentation, given that they have a Chiari, we'll always err on the side of dealing with the shunt first.
Thank you.
Yes, thank you very much. I have a question about Chiari 1 malformation and Syringomyelia across the lifespan. If a patient is diagnosed with Chiari 1 and Syringomyelia, I noted that patients should monitor for CSF leak. I guess as they get older, how often should this monitoring occur? And if at the time of adulthood, the patient is still exhibiting pain, what does this mean if they had, for example, if the patient had a decompression and a duroplasty when they were a child?
So are you saying syringomyelia or a myelomeningocele?
Syringomyelia.
In a child?
With Chiari 1.
So a CSF leak in that instance, it's either going to present or it's not. There's the pseudomeningocele that I think was discussed already, where that's more of a radiographic finding, where it's not coming out of the skin. So I think it actually would be a good poll, I think, for the panelists. I think everybody, and that's everybody does things a little differently as far as surveillance of.
I may have misunderstood. I don't know. I don't recall what CSF stands for. I thought it was like the.
You mean hydrocephalus?
No, the cerebral fluid that leaks down and creates the Syrinx. That's. I hope I'm understanding.
No, so not a leak, but I think what you're referring to, and you correct me if I'm wrong, is the Syrinx itself and the cerebral spinal fluid within the Syrinx. And again, we can open it up to the whole panel, but generally the Chiari decompression, about 80% of those, both in adults and children, will take care of the syringomyelia or the Syrinx. And generally within about 6 months, you start to see at least a pretty decent resolution, if not full resolution. I personally, in general, I will follow them until they are resolved. If they're after about 3, 4, 5 years, I would stop following that alone, especially if the patient's asymptomatic.
But what if the child is now an adult and is experiencing back pain?
Back pain?
Yes, what might that mean?
Well, then you need to look at something called a tethered cord, which often gets missed, or not missed, but it can resolve later. And I think my pediatric colleagues can probably speak better to that. But if they're having back pain as an adult, then an MRI of the lumbar spine would show if they have what's called a tethered cord.
Yeah, and to kind of add on that, I think, is it new back pain, worsening back pain, or stable back pain?
I think it's a stable back pain.
Yeah, so I would agree with a MRI of the lumbar spine, and of course you want to check for scoliosis and progressive deformity, and specifically kyphosis or arching of the upper back, which can be related to all these things too.
It also depends on the type of Syrinx. The central canal of the spinal cord, so there's fluid on the outside and going down the middle, it's lined by ependymal cells. So if that's dilated, it's a very different phenomena than if you don't have ependymal cells, if it busts through the ependyma and is involving the tissue of the cord. So that variation in hydromyelia, which means the ependyma is intact, those cells are intact, or a syringomyelia where those cells aren't intact necessarily, is a problem. It also depends on why the Syrinx is there. Did they present with the Syrinx, and are you following them and treating them for the Syrinx that's associated with the Chiari malformation, or are you dealing with a perpetuation of the Syrinx from a bad response to a graft material, an intraoperative infection, bleeding, other things that will create a different type of Syrinx, if you will, that can be a little more difficult to treat because they don't behave like a classical Syrinx would. So it really depends on the problem. And most often, I follow these patients for many, many years, but I'm paranoid. So the farther I follow them, the less often I get MRI scans. If the Syrinx remains the same size, I'm okay with that if they're asymptomatic. If it gets smaller, I'm okay with that if they're asymptomatic. Symptomatology then changes the approach and makes me more aggressive.
I'll also say, because I'm still a resident and therefore I treat everything and see everything, the most common cause of back pain is in an adult is going to be degenerative spine disease too. So those are other things that we need to look at, that as pediatric patients who are generally really healthy and have no problems and their bodies work great, as they become adults, they have a lot of the same problems that all adults have.
Speaking of Syrinx growth rates, so for someone who's recently diagnosed with a Syrinx but is low with symptoms, what is a growth rate of a Syrinx? Like, how fast do they grow? Is like, I know I have one, I don't know how long I've had it, or how long it's going to take to become a problem. Do you have any information or research on that?
I think it depends on like what caused it, whether it was trauma, is it incidental, is it associated with the Chiari? It really varies. Many can be almost incidental findings, and patients are minimally or asymptomatic, and they stay the same forever, and they really don't cause problems long term. Depending again on the etiology, if it's a pressure-related issue, there's Chiari, low-lying cerebellar tonsils, they can get bigger. So it really depends on the etiology of why, what's causing it.
Yeah, and I think it's important to know, and think about it. An MRI is one picture in time, right? So for me, you need at least 2 or 3 data points to really know where things are headed from a natural history standpoint. So if this were my patient, I would say, you're asymptomatic. Let's do a follow-up MRI in 3 to 6 months, and we can ascertain what it looks like at that point, and then your question can be much better answered.
I have a question about my daughter. She was diagnosed as Chiari 1.5, and she had the surgery 2 months ago. And then before she had the surgery, she has numbness on her right arm. And after the surgery, like 2 months later, she developed new symptoms. She had this numbness on both arms, so left arms also had this numbness. So I just wonder if it's normal that you have new symptom after the surgery, or if it's because she danced Lindy Hop, and she did like weightlifting. Is that because she did those things, or she need a second surgery or something like that?
Did her neurosurgeon order any new imaging after those symptoms developed?
No.
No, I would probably start there, because as surgeons, and I know I'm learning this, and all the panelists certainly know this really well, is that it's hard for us to treat things without a picture. So there needs to be a structural problem or something structural going on in order for us to know what to do about it. So that's usually going to be our first move, is if there's a change or if there's a new symptom developed, that we need new pictures to see if anything has changed.
Yeah, because she called the office and she can't reach the neurosurgeon directly. So the nurse told her just to wait to see. So I just wonder.
Dr. Levy will see her. What state are you in? Mike, I'm giving your number. Yeah, I mean, I think there's going to be a common thing that you're going to hear from everybody. You have to be a proponent. That's not an okay answer. So, and I don't know what state you are, whatever, so I hope I'm not getting myself into something with one of my colleagues, but that's not appropriate. You have to mandate and, make sure that gets done, because that's exactly right. New imaging has to be performed because it's impossible to determine what's going on.
Okay. Yeah, because it's hard. I feel like after the surgery, we never get a report on what the neurosurgeon did for the surgery. Because we don't know if the civic bone is cut or not, or how big is the bone removed from the skull. And then after the surgery, we can only contact the office through the nurse. So if the nurse says you have to wait, we don't have a chance to to contact with the surgeon. I don't know if it's normal because I called the office and they said, okay, we will send the nurse to talk to you.
Have you had a post-op visit?
That's after 1 month. So that's like first month and the third month. So we are in the second month. And
Yeah.
this happened.
So again, I think just you have to be a very strong proponent, be aggressive, and demand to speak with them, and ask to just keep calling and saying your demand to speak to them, and at that point, then it may be time for a second opinion.
Okay. Okay. So this is something we should really
Yeah,
be
and
serious
that's
about that.
clearly it's I mean,
Okay.
surgery was done, and if things aren't okay, that 100%, that's a responsibility. That's our responsibility as physicians to make sure we're following up with that and answering your questions.
Okay. Thank you.
I have a question. I was diagnosed in '89. Now it's affecting my throat. I had surgery in '90. I've lived with chronic pain all these years, but I've tolerated it, we've managed it. Now, after all these years, I'm having trouble with the pain increasing, losing strength in my hands, fowls totally stopped working. So I had the MRI done again, sent it in. I was told I don't have a tethered port, so there's nothing that could be done. So I'm just curious, what do I just go on living this, or after all these years, does anyone have anything?
So have they kind of investigated other parts of your spine also? Are there, reflexes and your other neurological function? Because, this may be related to a unrelated problem of degenerative disease in your neck, cervical myelopathy, something like that.
Okay. I haven't done anything, though. Unfortunately, it's Kaiser.
Yeah, I think my old boss used to say this, when you're a hammer, everything's a nail, right? So we do get tunnel vision sometimes, especially in something as nuanced as Chiari malformations. But as Dr. Plonsker said, there's Chiari malformations and everything else, and common things being common. All of our spines are degenerating as we sit here and speak. And that sounds like it could be directly related to that.
Okay, but wouldn't it be nerve?
Could be, but in someone who's had a Chiari operation previously, and I'm speaking in generalities here, right? It can be an atypical type of presentation.
Okay, thank you.
Quick question again.
Oh. Sorry, do you want to go ahead up here? I know you've been waiting for a while here.
Eric,
Yeah.
Hi. On the other young lady's thing about subpart care and with some of the doctors, I'm from Northern California, and if it wasn't for my doctors, Dr. Bolognese in New York, and first at the Chiari Institute, now at the EDS Center, I really, and with Dr. Kula when he was practicing, I really would be in trouble with care because Dr. Bolognese is amazing, been keeping me alive for a long time. No, it absolutely fabulous because he still takes care of me because the doctors they don't know how to deal with Chiari and an adult with spina bifida and all my illnesses. They have no clue in Northern California, with the hospitals there, and it really was, it makes me, it would make me nervous if I didn't have Dr. Bolognese. If something would happen.
How much did he pay you to say that?
You are, but we want to stay down here, but we're going to move away from Northern California to try to see if we can come here because I have a lot of illnesses due to, I was born with spina bifida, and then I have a lot of congenital and secondary congenital illnesses before and hypermobile EDS and small fiber, all these things, and Klippel-Feil syndrome and the cervical Syrinx, a lot of things. And, doctor, I don't know if there's, things down here that can help me definitely better than there. I know, but. But he's amazing, Dr. Bolognese. You know it, and you could.
Mira taught me, a bunch of other people taught them.
I know,
so
but
it's a community.
I've been a patient of yours for over 20 years.
It's not a monopoly. It's not a mafia. There are a bunch of people.
Yeah, but you're one of my favorite people, so it's okay.
He's being humble, but the relationship that you have is the relationship that you should have, and that's the relationship you deserve for your child. And so that's what you need to pursue.
Agreed.
But I mean, Dr. Bolognese, Dr. Cool, everybody, he takes care of you like you're the only patient he has, and that's I don't have that here in California. I'm used to, I'm used to that kind of treatment, and
yeah, but this association is just like this: is to bring young people in. I was recruited, I was kidnapped and recruited by Mira. Other people are going to grow up. They're going to come into this. Yeah, I'm almost retired, so this association brings up new people, put them in to take care of more people.
Yeah, because I want to, if there's people this way, that can help me. Yeah, because they have low back pain and myelopathy, and we can't depend on one thing,
Initiate some contacts to try to figure out a way to transfer the care to Southern California.
Because all they just dismiss, they don't know. And they're like, there's nobody that can take care of anybody with spinal different that's an adult or have issues.
They forget that people with it grow up and become adults.
My question is, based on some of the things you guys just talked about earlier, that MRIs afterwards. So we're blessed. We're here in San Diego. We've had rabies for my daughter for her surgery when she was 15. Now she's an adult. So the complication we have now is we're no longer rabies and getting that care. We're now trying to find adult care. And as someone said earlier, you're having to educate your doctors on what Chiari is. So it's very difficult to find adult care that matches your insurance. But we had our 3-month post-surgery, had the MRI, which showed the Syrinx reduced, which was great, but symptoms that consist still up into 21 years old, still as an adult. Would you recommend having an MRI again? Because everywhere you go, getting an MRI is next to impossible. Or, because I heard about the MRI questions, is there a timeline, like a year out, 3 years out, 4 years? Is there some type of timeline that patients should have as an education question, getting MRIs to kind of check up?
I would say there is no kind of cookbook for that. If there's symptoms, I would probably recommend a repeat image. And I work at the military hospital also, so a lot of my patients are kind of fleeting. So what I try to do is really find a adult person or someone to transition their care directly to. And I think that if you had your care at Radies, I'm sure they could do that for you, is find someone and identify someone that they trust that can handle adult Chiari type of problems. And every neurosurgeon that takes care of kids has that person or has people that they can think of that they would pass their patients on to. And I would advocate that everybody kind of demands that from their surgeon because it's the right thing to do.
Yeah, that's a really important statement that was just made, and that's the right way to do it because, as you know, what happens is pediatrics, there's this really tight bond, and then all of a sudden you're in the adult world, and there's this disconnect, and even in the best of hands. So, that's exactly right. The teams that do this and are doing it right will do exactly that, have this transition, talk about, from the surgery to the initial diagnosis to how they're following them and go from there.
It was mentioned that trauma can cause Syringomyelia or Chiari, and I was just wondering, in adults, what's the incident rate of that, the adults who have it is from trauma, such as say, whiplash in a car accident?
No, it's not the Chiari is caused by trauma. Trauma precipitates the symptomatic conversion, which in English, plain English, means this. You have a Chiari-1 malformation, doesn't give you any problem. The trauma shakes you up, and all of a sudden your brain is no longer happy to be compressed by the Chiari, and you become symptomatic. We do not know the cases worldwide, but in the United States it's been estimated that 28% of the people who come to surgical attention and ends up having a surgery, this is what is used in courts of law for obvious reasons, they experience a trauma. The three most recurrent trauma are whiplash injury from accidents, or number two is actually trauma from childbirth, which can be a combination of things, push, or the epidural which went too deep. And since I'm old now, I don't remember the third, so forgive me about that.
Thank you.
Hello. My name is Will.
There are only two causes.
Hi, thanks. My name is Will. This is my first time here, but I've been following this group for the last 3 years, and it seemed to me that there was a lot of controversy about the definition of the Chiari and when to operate and when not to operate, and I'm sure that you're going to discuss this throughout the week. But as the group of panel is up there right now, would you say that you're doing more of these surgeries now, like in the past year? Is there's traction, or is there some shift in the thinking that more candidates or more patients are candidates for surgical intervention?
I can speak from the pediatric side, which is most of my practice. I would say the answer is no. We do a lot more imaging now for a variety of reasons, whether it's accessibility to imaging after trauma or kind of fear of medical legal, that there's just more imaging being ordered. So more and more Chiaris are being diagnosed, but I don't think the criteria for surgery has really shifted. There are hard indications to do surgery as the presence of a Syrinx in my mind. Progressive scoliosis is something I look at, and symptoms that are attributable to the Chiari malformation. So we might be seeing more Chiaris, but I don't think we're doing more Chiari surgery. And I don't know if you guys would agree with that.
Yeah, my practice is 16 years and up, and mine's exactly agree. I'm not doing more surgeries, but certainly more being diagnosed, I think, as a whole, because imaging is becoming much more common. And better, yeah.
Okay, so we're just going to take two more questions, and then we're going to wrap up for today so that everybody can get up and make sure that we're down for the buses for the zoo trip by 4:15. So 2 more questions. There will be plenty other panel discussions throughout the rest of the week, so don't worry. You'll have an opportunity to ask more questions, but we'll go ahead and take the next two.
Hi, I am 24 years into a post-traumatic syringomyelia, since C4-5 to T12. And as I'm aging, I'm 24 years into this, it's been a really interesting ride. But as I'm aging, I'm starting to do that thing where I have to pull apart, like, what is what? I have chest pain. Is it chest pain because I have a cardiac problem, or is it because my rib is kicked out and I've got an MS HUD going on? So I'm starting to win my way through the what is what stage of things, which has been a lot of fun. I am interested in asking a question that has to do with shoulder arthropathy. Charcot joints, shoulders, elbows, feet, or ankles. There's a lot more literature that's being published about neuropathic arthropathy, and it's associated with the presence of syringomyelia. So especially with regard to shoulder and upper extremity joints, also in the hips, there's x-rays showing bony destruction in the joints, and I am wondering if any of you guys can comment within your practices on the frequency of this, and also once it's diagnosed, if there's any suggestions you can offer to minimize the risk of its occurrence or manage the symptoms once it occurs.
Okay, I go. Yeah, because with pediatric neurosurgeons are not going to see Charcot joint. Charcot joints are something which develop later on. Number one, Charcot joints, right now, we're seeing them less. Charcot joints come from the fact that for the Syringomyelia model, they can come for other diseases. But when you have a Syringomyelia grows from the inside out, and it compromises, practically kills certain fibers passing by. And so all of a sudden you have a disturbance of what is called the neurovegetative fibers going to the joints. And you cause that the skin becomes strange. You have that kind of chronic swelling of the joint after a while deforms. So it definitely takes several years. Why now we're seeing less? Number one, now we're doing more MRIs than we were 40 years ago. 40 years ago, the MRI did not exist. So the diagnosis of Syringomyelia happens more early. So you don't have the Syringomyelia ravishing the spinal cord for several years and then ultimately causing the Charcot joint, which is a slow process. Number two, even if you have, and there are 18 different causes of Syringomyelia. So Chiari is the most frequent. It covers about 75% of the Syringomyelia cavities which are around, and then all the other 25, there are 17 other causes. But in your case, it was post-traumatic. The other thing is, it depends what's the timing between the time you find the Syringomyelia cavity and the time you address the cause. So if the Syringomyelia there is, when you decompress the Syringomyelia in pediatric cases, the kids bounce back phenomenally. Syrinx disappears, the spinal cord flourishes back like the Syrinx was never there. In an adult, the more it stays there, the more it creates a wear and tear. So first, the insulation of the fibers passing by goes away, and then ultimately the electric cables go away. So you have a progressive atrophy. The progressive atrophy, the progressive wasting of the nervous tissue is what leads to Charcot. Now, what can be done? So that's why we're seeing it less, because we identified the Syringomyelia earlier. We're becoming, less klutzy about addressing the causes. We have a better success rate because, the more you try, eventually you get better. But the issue is that, okay, now we are too late. What can we do about it? And one of the things we can do is to decrease the sympathetic tone. Neurovegetative system gets messed up, and all of a sudden you have an excessive surge of sympathetic signals which are coming there. And, our body likes balance between the yin and the yang. So all of a sudden there is an excessive sympathetic. So what's the thing we can do? The first thing, to give you medications. But if you have bad Charcot joint, it's not going to be enough. So they can do, orthotics. So at least in weight loading areas, they can make it more comfortable. But the key is going to be to cut down the volume of the sympathetic incoming tone. So if it goes to your arm, there is a big center way over here by the shoulder that can be first injected for screening, and then it can be burned up, or it can actually be cut with a thoracoscopic thing, and that's actually the easiest. The bigger problem is down there, when you go below the belt, because the sympathetic fibers are less concentrated, so you have to go in areas behind the peritoneum. But now with the current techniques, is becoming easier. But so bottom line, cut the power of the sympathetic, and you're not going to cure the patient, but you're going to make the patient less uncomfortable. Okay. Then right now they're also doing some. It's not experiments, but patients like you want to be compassionate. You want to, if whatever you do is not enough, you're exploring other things, and IVIGs and stem cells. First of all, IVIG and stem cells right now, there is not a unified protocol. So everybody has their own recipe, and whatever is kind of a hit or miss. But But these are the things which show some kind of promise to give you that additional level of comfort, because here we're all adults here. There is not going to be a cure for a Charcot joint, but what the realistic goal is to make you more comfortable and more functional.
So with it being though a CSF issue that helps under innervation issues in the joint, there seems to be a lack of understanding of safe physical therapy practices or exercises for people like us.
No, that is the physical therapy part is very plain and simple. You want to keep the joint moving. The point is that if you go to a physical therapist who's never seen something like that, you see the massive swelling, and you would have the same knee-jerk reaction you would have with somebody who just broke the damn arm. You say, I'm not going to touch that, just rest. The point with the Charcot joint, the more you rest, the more it gets worse. So it's a matter of experience. You go in places where, unfortunately, they've dealt with a lot of advanced Syringomyelia, like in the past when I was their age. Okay.
I'm not going to say how old that is.
When the TV was in black and white. But when I was younger, the majority of the most complicated cases of Syringomyelia, they were going to the University of Miami. And over there, they have this big center, and they were trying many different things. And the physical therapy part was, the cornerstone of everything. So, the point is, every time there is a difficult problem, if you focus it, if you concentrate it in time and space in one place, you're going to create more expertise. And now, if I had to say, one of the problems of Chiari 1 malformation is that when I was growing up, there were 5 or 6 titans, which before were the go-to persons in Chiari. And these guys were having enormous numbers and enormous experience. Right now, for different socioeconomic reasons and whatever, Chiari 1 malformation care has been more fragmented, which is good because people don't have to travel that much, but it also means that you're going to have the same experience which was concentrated in 4 or 5 people that now are retired is now more diluted. So it's good and bad.
Okay, thank you, doctors. Thank you, everybody, for all your questions.